And it was an excellent talk, Dr. Tang. And let me share my slide. So can you find my slide? Good?
Yes, okay.
Yes.
Thank you. So thank you very much for your invitation. And today I would like to talk about arthroscopic management for primary elbow osteoarthritis. I'm In Ho Jeon from Asan Medical Center. And before I start my talk, let me have a quick view on my hospital. This is Asan Medical Center, downtown in Seoul, capital. And we have a huge three clinical building and separate research building on the opposite side. And we are proud to work in the biggest hospital down in South Korea. So as many of you have visited here before, because of various reasons, we are pursuing the best clinical practice in South Korea. So we have our shoulder and elbow team. It's a very heterogeneous and diverse team. We have Saudi fellows, we have a fellow from Indonesia, and also we had a fellow from Vietnam, Dr. Tan. Dr. Tan, when he was with us, he worked very hard, and thankfully he and me, we could publish one paper in Journal of Arthroscopy about arthroscopic assisted coronal shear fracture fixation. It was an excellent case review because we did a very good intra-articular reduction and fixation arthroscopically, which has not been performed very well in other parts of the world. So once again, thank you very much, Dr. Tan. And today, I'd like to talk about arthroscopic elbow. When I review my clinical practice for the last 10 years, the arthroscopic elbow surgery is increasing year by year. Now its total number is around 300, but it started from less than 10 in the beginning. So here's my first question. What do we know about elbow osteoarthritis? Do you know where the arthritis starts? In the knee joint, we know the patellofemoral joint, medial compartment is more involved. But what about the elbow? Back in 1967, two British surgeons, they found interesting papers. What they found was in a cadaver, there's a certain pattern of arthritic change in the elbow, which involves the radiocapitellar joint first. So why is that? So we looked further into our cadaveric study, and we found very interesting structure. During pronation and supination, can you see there's a certain change? Yes, here, the gap between this lateral trochlear ridge and the radial head, this is opening up and close. What is the meaning of this zona conoidea, which is here, this ridge? This ridge is the axis changes here. So elbow, because you have a two axis of freedom, flexion, extension, pronation, supination, it's not like this parallel here. Elbow is more likely this right angle, sorry about this, right angle here, so that you have a more friction during flexion and extension, pronation, supination. So when you have a right angle axis, you have actually better performance, but unfortunately you have a more abrasion. That's how we have arthritis in this point. So the spinning upon each other, pronation, supination, flexion, extension, this is why we have arthritis in this specific point. So if I can remind you here, this is the point where the elbow osteoarthritis starts. So we looked further into the radial head. Radial head, as you all know, is not really circular. It's more like the ovoid shape. So we did a study in a human radial head. This radial head, posterior medial corner, which is articulating with the zona conoidea, has a thicker cartilage and dense subcondylar bone, which means you have a more weight force transmission at that point. So now we understand why they developed in 1967, why they said, okay, there's a certain pattern of arthritis where you have arthritis here on the ridge of the lateral trochlea. So this is the beginning, but in a clinical setting, we can hardly see this case because when the patient comes to you, usually they come to you with this elbow. This is the CT scan of typical elbow OA. Now you can see a lot of spur in a coronoid tip, more spur from coronoid fossa, and also here olecranon fossa and olecranon tip is involved. So this anterior compartment, posterior compartment, both involved. This is a bony spur. What about the capsule? Capsule is less involved, but they lose their flexibility. So during the surgery, you have to understand where is the capsular attachment on the humeral side and radial head and ulnar side. Then we can do a capsular release properly. So capsule should be very redundant. What about the operative indication? Absolutely any functional range of motion from 30 to 120 degree is not surgical indication, but any patient who's got a pain at terminal extension, at terminal flexion, it can be looked very carefully with CT scan. Now we are doing arthroscopic osteocapsular arthroplasty. We are expecting less pain. Of course, intra-articular bleeding is less, and only exercise and rapid return to function as like any of the minimal invasive surgery. But you have to remember, these patient who's got a prior surgical management, huge soft tissue flap or extensive heterotopic ossification, skin graft, burn, these are not very good indication for elbow arthroscope. So this is my surgical procedure. We do a patient position on the lateral position, but we have to have this arm holder, and you can mobilize the elbow full flexion during surgery. Otherwise, this is going to limit your arthroscopic view. I use the same arthroscopy which you use for knee and shoulder. And this is particularly important because you need to have a very good landmark, surface landmark. This is medial epicondyle, and this is the lateral epicondyle, and this is a triceps, and this is ulnar nerve. At least these 4 points should be very carefully marked. Otherwise, we lose our orientation during surgery. Now let's have a quick look on the video. This is a left shoulder and patient on the lateral position. So first, important landmark for proper portal, okay? So this is olecranon. Now I marked medial and lateral epicondyle. And then I feel the supracondylar ridge along this humeral, distal humerus and lateral epicondyle, and I can feel the radial head. And then mark the triceps. This is the ulnar nerve I marked, because when patient has any ulnar nerve subluxation, it is important to avoid the ulnar nerve. And this is going to be posterior central portal, and this is going to be posterior lateral portal. This is 2 portal for posterior, but I need another 3 portal for anterior. Superior, anterolateral, superior, anteromedial. So this is a patient who came to me with the pain at elbow extension. So now let's have a look what is happening to her elbow. She's got a pain at elbow extension. In the plain X-ray, it looks okay, but in the CT scan, you saw this spur, olecranon fossa. So spur around this olecranon fossa, you can remove it very easy with the acromionizer, with the burr. And then, of course, you can trim the tip of the olecranon tip together so that there's no more bony impingement. So during flexion and extension, you double check where there is any bony impingement. So if there is any kissing lesion, we can debride with the burr. So this is how we do extension block impingement. And this is a very classic elbow osteocapsular arthroplasty. Now I'd like to share with you. This patient came to me with the elbow pain at terminal flexion and extension. As you can see here, you can see the spur in the front, spur in the back. This is very good indication for elbow arthroscope. Now my scope is from proximal anteromedial and my portal from the lateral for instrumentation. So now you can see the capitellum here, radial head here, and the instrument working portal come from the proximal anterolateral. So first, we always have to debride the bony spur first. Because why? If you debride soft tissue first, your joint can be blown up and you lose your working space. So as I do, first we need to remove all those bony spur first, okay? And always keep this capsule and soft tissue in the front intact. And then what I need is I need to change scope to the proximal anterolateral because now I'm going to work on the ulnohumeral joint. This is the major bony spur, olecranon fossa. And once you remove a spur, now time to remove coronoid spur. You see the coronoid spur sometimes difficult to remove with the burr, so we use an osteotome to trim the tip of the coronoid. So during flexion and extension, you can check whether you removed enough coronoid tip. And after you remove all this bony spur, now time to remove this capsule. Capsule you always remove from the center of the elbow joint because we know where the radial nerve is. Now we are moving back to the olecranon fossa posterior compartment. Posterior central portal is your scope view, and same as like the knee intercondylar notch. Because of fat pad, you cannot see, but once you remove all this fat pad, now you can see the olecranon spur. Okay. And during flexion and extension, you can see where is the spur, and you can use this osteotome to remove these spurs. And careful not to leave any spur inside. And same as like the knee, you can access to the medial gutter and lateral gutter. But always have to keep in mind posterior medial gutter, always there is an ulnar nerve. So basically, if I summarize, you have 4 major steps. You have to remove loose body first so that you can have enough working space. Second, you need to remove a osteophyte bony spur first so that you can have a good flexion and extension. And then remove synovium and the capsule so that you can have a full. So ladies and gentlemen, actually not many people like to do an elbow arthroscope because of this. You have a median nerve in the front, radial nerve right in front of radial head, and also brachial artery there. So what if we injure this nerve? That is why we would like to avoid arthroscope. But keep in mind, there's some tips you can avoid nerve and artery injuries. Whenever you are down, always do open. Mini open, the result will not be very much different. So when you lose your orientation, please do mini open rather than doing arthroscope. And keep this joint distended with the cell line and always use a switching stick. Okay? So this is tips how I do. And second, while during surgery, you always keep your elbow 90-degree flexion so that you can away the anterior capsule from the bone. But keep in mind, this capsule, which is marked with the red, is close to the radial nerve. Okay? So during your flexion and extension, capsule and the radial nerve distance is same. So even though you flex your elbow, distend the elbow, always capsule and nerve is closely connected. And this is my another surgical tip. This is a elbow scope without retractor, intra-articular retractor. But this is arthroscopic view with the retractor. So this retractor is actually giving you a good view and blocking all the soft tissue away from arthroscope so that you can have a good working space until the end of surgery. So you have to remind this radial nerve is right in front of radial nerve between brachialis and brachioradialis. So from the proximal anteromedial portal, this is a brachialis and this is brachioradialis. The deep branch of radial nerve is right there. It's very close to the radial nerve, so we have to keep in mind that nerve is frontal radial head. This is an interesting case of mine. This patient came to me with the elbow stiffness because of elbow OA. We did at that time we did the OK procedure, opening the olecranon fossa, and we gained a quite amount of elbow flexion and extension. And after surgery, patient had ulnar nerve symptoms. So why? We did the ultrasonography, ulnar nerve completely empty. So gentlemen, this is the same as like your knee stiffness. If you do the surgery for high-grade knee, high-grade stiff knee, after total knee replacement, you gain full extension, then what happens? Your peroneal nerve is pulsing. And this is the same for knee. If you lose your elbow and then you flex it hard during surgery, the nerve behind your medial epicondyle is going to be tethered and it's going to be all stretched out. So whenever you're suspicious of ulnar nerve symptoms, do this ulnar nerve decompression first. You can do endoscopic assisted as like this, or you can do mini open. It's not a problem. Or if you have a good skill of the elbow scope, it's okay. You can do a release, posterior medial release, gutter release, and then you can release the ulnar nerve intra-articularly. But always keep in mind, high-grade stiff elbow, always you have to release ulnar nerve for prophylactic purpose. We have done a good number of primary osteoarthritis arthroscopic surgery over 75 patients, and the result was quite good, almost comparable to open procedure. However, if you do the open procedure, you actually can gain more flexion, which I would like to say later on. So, because you guys are very expert in the knee and the shoulder, so just to remind what we know about osteoarthritis. In the knee joint, knee is a weight-bearing joint. We have symptoms because of cartilage degeneration. So main symptom is a pain. But non-weight-bearing joint like elbow, mostly symptom comes to you with the stiffness rather than pain. So when you have osteophyte, they lose their range of motion. They have a pain and flexion and extension. But once they lose their cartilage, they have a resting pain. So even though these pain, same pain, but different characteristics. When you have a cartilage degeneration, it's a resting pain, be the arc pain. But when you have osteophyte, it's a terminal pain and terminal flexion extension pain. So you can treat this osteophyte-related pain, but it's very difficult to treat cartilage-related pain. So here's a classification I would like to share with you. Dr. Mori from Mayo Clinic proposed this classification, grade 1 to 3. But if you look very carefully, this is not very good because based on the plain X-rays. If you look at this CT scan, the plain X-ray and CT does not really correlate. So no clear definition, sometimes it's a mismatch. So here I would like to suggest you, CT scan is essential for investigation of elbow arthritis. Okay, you can see the spur in the front and back. Sometimes joint space narrowing is more clear and precise if you do the CT scan. So this grade 3, if you have already joint space narrowing, this is advanced elbow arthritis. But here only spur, this is early stage and mid stage. So interesting, grade 1, 2, early to middle stage and late stage grade 3, you can do the surgery and both group, you have a good range of motion, okay? You do the surgery, you can gain range of motion. But ladies and gentlemen, this is a different. Their pain and function, not good. Because even though they gain more flexion and extension, this advanced elbow arthritis, if you do the scope, they have a persistent pain. So why they have a persistent pain? Because they have loose already arthritis and arthritis progress. So this grade 1, 2 is a very good indication for osteocapsular arthroplasty, whether open or scope. But grade 3, you have to consider very carefully when you do the surgery because arthritis eventually will progress. So pain is not simply pain. You have to make sure whether this is a resting pain or terminal pain. Terminal pain is caused by spur, but resting pain is coming from cartilage destruction. Increase the range of motion is good, but sometimes when you gain more range of motion, they have more pain because they have a more contact of the arthritis. So this is my last slide. When you treat elbow arthritis, always think about whether it is coming from stiffness or cartilage degeneration. When you plan a surgery, always a CT scan is essential for your planning of surgery. And when you meet patients with advanced stage elbow arthritis, you have to consider again whether they are good indication for surgical treatment. Thank you very much. Over to you, Mr. Moderator.
Professor In Ho Jeon, it's very impressed me so much about your research about the elbow region, and very impressed me about your techniques in elbow arthroscopy. Cảm ơn Professor In Ho Jeon về cái bài phát biểu, xin lỗi, về cái bài báo của ông rất là hay về cái vùng khuỷu, các cái nghiên cứu về cái vùng khuỷu, đặc biệt là cho chúng ta một cái concept mới về cái gọi là zona conoidea, là một cái vùng giống như cái vùng nón, cái vùng tam giác giữa các cái khuỷu. Mặc dù là cái giải phẫu vùng này là chúng ta cũng khá là nắm vững, nhưng mà hôm nay chúng ta thấy được một cái concept là khá là mới, và cũng như là cái bài của ông nói về các cái kỹ thuật về nội soi vùng khớp khuỷu rất là chi tiết, rất là hay và rất là ấn tượng.